over the next 20 minutes, we will see the fascinating topic of inflammation as it applies to nutrition of patients with renal disease. So I'll talk about the epidemiology, pathophysiology, the link to malnutrition, clinical recognition, therapy, and future. Inflammatio is a word. Inflammation has come from the Latin word inflammatio, and we are all aware of this the Calor, Ruber, tumor, dolor, and functio laesa. So what we see in inflammation in chronic kidney disease is not all the aspects of this inflammation, but functio laesa, that is the loss of function, is definitely there. And as far as inflammation is concerned, there are two pathways. The first one, when the inciting agent starts it, inflammation removes it, and we have a happy ending, healing. In chronic kidney disease, the inciting agent is festering and inflammation cannot remove the agent, and there is systemic damage. So there is collateral damage when there is inflammation. So how do you define inflammation in somebody with chronic kidney disease? The definitions vary, but we see that at least up to date says that elevation of CRP for 5 milligrams per liter for more than 3 months is a good working definition for our day-to-day practice. And we have seen that almost 50 to 60% of our dialysis patients in Europe and US have inflammation. And it has been shown in Asians that they are slightly at a higher level of inflammation, especially because these studies have been come out from Japan. And so you have, because of the enormous seafood eating, they probably have less of inflammation. And why is CRP a popular choice? It has got a very stable molecule with a half-life of more than 15 hours, and it is easy to measure. It is produced by liver under the influence of IL-6, and it stimulates alternate complement pathway. What is important is that you can monitor the inflammation and monitor the treatment of inflammation also, and it has got a very, very heavy and independent risk factor for mortality in chronic kidney disease. So what about the epidemiology? As we age, we became more inflamed, and diabetics are more inflamed. And as far as the race is concerned, the Hispanics and blacks are more inflamed. And when you have the contribution of the proteinuria and the reduction of GFR, you will find that the highest tertiles of inflammation happens in those patients with the lowest GFR and highest levels of proteinuria. So there is an element of retention of these molecules in the presence of low GFR, and that also contributes to the inflammatory milieu. And the more inflamed the patients, the more progression is going to be in early stages of CKD. They will very quickly progress into later stages when they are more inflamed. And what are the markers? These markers are increasing. The number of these markers which are being studied are increasing by the day, by the hour. And the levels of CRP, you have the albumin, which is the negative marker of inflammation. IL-6. IL-6 is an interesting molecule because you have pro and anti-inflammatory effects of this IL-6. How it binds to the receptor is what is important. When it binds it along with a secretory molecule of this receptor, then it becomes more and more inflammatory. Whereas if it is binding on to the cell surface with a glycoprotein 130, it seems to be pro or anti-inflammatory. So another good set of rules for a patient, for a clinician, is that when somebody is hypoalbuminemic and you check the CRP levels, if the CRP levels are high, then you can say that this patient is inflamed, and so that is why there is hypoalbuminemia. And on the other hand, if somebody is hypoalbuminemic with a normal or slightly elevated CRP, then you can think that very aggressive nutrition therapy will help, because it is all nutritional. Most often you will find that there is an overlap of nutritional as well as inflammatory factors underlying the hypoalbuminemia. And you can see that I have counted 46 markers for inflammation in CKD, and this count is going to go up. Broadly, they can be divided into positive and negative factors. The negative factors are being albumin and transferrin, and CRP, IL-6 and ferritin are the positive factors which will tell us about the increasing inflammation. So why are CKD patients inflamed? I think there are multiple reasons. This will be two. It will itself engage 1 hour. So I'll just run through. Then you have occult infections, most often in patients with who are on dialysis. This could be a biofilm sitting on top of a central venous catheter, or an occult infection like tuberculosis, which can predispose towards inflammation. And you have the oxidative stress and carbonyl stress, and the dialysis water could be the reason for the inflammation. And now we have centers coming up with ultra pure dialysis, where this inflammation is being taken care of. To some extent, this does reduce the problem of inflammation. You have the leaky gut. When somebody is highly fluid overloaded, then bacterial translocation occurs across the gut, and that again can predispose towards inflammation. And a lot of it is due to uremic retention. For example, CRP, IL-6, all of these are retained in patients with chronic kidney disease, and they do their damage. And we can't dissuade the comorbid conditions. So you have the diabetic patients and other chronic heart failure patients who are also more inflamed. So how do we define protein energy wasting? The other part of the link. We have so low serum albumin symposium about the sarcopenia, the weight loss or low BMI. So how do we make a diagnosis of protein energy wasting? Serum albumin less than 3.8, BMI less than 23. So you can count me in as one of the protein energy wasted fellows. 23 kg per meter squared. Deficient dietary intake, 0.8 grams per kilogram per day of protein for at least 2 months in dialysis patients. So what will be the link between this and the muscle protein catabolism? You see that there is insulin resistance, which happens all the time with patients with chronic kidney disease. And insulin resistance is a part and parcel of muscles intracellular metabolism. And once the insulin is prevented from its activity, then muscle catabolism happens. And once muscle catabolism starts, then it is itself as a source for the acute phase protein synthesis. And altered neuroendocrine signaling and depression we'll see. So you have this IL-6 CRP, which increase the muscle protein catabolism through the proteasome system. And there is a difference between the CKD related sarcopenia and aging related sarcopenia. So you have this aging related sarcopenia where there is no change in the protein degradation, and the protein synthesis is decreased. Whereas in CKD, degradation increases, synthesis decreases, and the resting energy expenditure also increases. This is because of the sympathetic overactivity which happens all the time in patients with chronic kidney disease and inflammation. So you have every reason why muscles get catabolized. Anorexia, we can have all the food that we have in front of us. I already have the pizza which has been ordered by the conference organizers. It is sitting in front of me. So unless you are having the appetite, then you're not going to take it. So anorexia. So you have all these hormones, leptin, serotonin, neuropeptide, Y, IL-6, TNF-alpha, all these, ghrelin coming from the stomach, all these are having the neuronal activity by preventing or disturbing the neurotransmitter activity, which will again give rise to anorexia, depression, and cachexia. So not every investigator who has studied this topic agrees that inflammation and which came first, whether the chicken or the egg. So there are people who vouch by the fact that inflammation was the starting point of protein energy wasting. They always say that there are multiple predictors like TNF-alpha, IL-6, all these levels will tell you about the energy wasting, and dialysis patients have intact appetite and still they have weight loss and low cholesterol level, which is linked to high inflammatory markers in dialysis. And the naysayers tell us that the correlation coefficient between the albumin and CRP is not precise, less than 0.5. And non-fluctuating serum albumin levels, unlike CRP, which fluctuates all the time, albumin levels don't fluctuate. So if it is going to be an inflammatory marker, it should be fluctuating all the time. Serum albumin directly reflects the protein intake independent of inflammation. And serum albumin improves with nutritional support. You're not doing anything for the inflammation. You're just increasing the nutritional support. Still, albumin improves. But whatever be the debate, the stark facts are that if somebody is inflamed and somebody is also protein energy wasted, then he is staring at death. So you can see that over the 5 years of follow-up, when somebody has a SGA score of more than 2 and a CRP level more than 10, then the survival is going to be the lowest. So you have to break this nexus. Interventions to break the unholy nexus between inflammation and malnutrition. These are the multiple levels. I will not be able to go into each and every detail. I'll just highlight that you need to have preventive nutritional counseling and guiding, and you need to optimize how you provide dialysis for these patients with ultra pure water, biocompatible dialysers, hemodiafiltration, etc., etc. Treating the comorbidities are extremely important. There was a beautiful talk about acidosis correction. Depression has to be taken care of, diabetes management. Inflammatory sources have to be removed. So this is one which could be important. So you may have to remove a rejected graft or a clotted AV graft. So you may have to remove all these. Nutritional interventions we'll see. So dietary intake. So the dietary intake should be more than 1.2 grams per kilogram in hemodialysis and PD patients with phosphorus restriction and a sodium restriction. In fact, it has been shown that even sodium excess is one factor which can increase the inflammation. Adequate calories are important. Optimize the renal replacement therapy, and we have some studies which is coming up from the Europe about the hemodiafiltration like contrast and Riscavide, where it has been shown that these molecules are reduced and the nutrition has improved. Comorbidities have to be treated, and oral and parenteral nutrition. So when standard preventive methods fail, we need to start, and even before that, it will be a good idea to prevent this unholy nexus from taking charge. So you will have to provide them with good oral and parenteral nutrition. I have not taken up parenteral nutrition in a large number of my patients, very few. In fact, a French study has also shown that if the patient can eat and if the patient is able to have a reasonably good intake, then oral nutrition will be their way to go. So you need to double up as a nutritionist and also a physiotherapist, and a combination of isometric and isotonic exercises with good physiotherapy will be the way to go. As of almost 90% of the studies, well-intentioned studies in nephrology, you have this pedal study where they try to do a lot of pedaling in the intradialytic exercise, and the recent report have shown that this is a 6-month intradialytic aerobic exercise program was not clinically beneficial in improving the quality of life. But nevertheless, we need to be aware that the exercises may not be intradialytic, but at least counseling about the exercises, regular exercises to be taken up on non-dialysis days by the patient is very, very important. So IF targeted approaches could be drug manipulation of cell response, source reduction, and direct suppression. So you have a variety of therapeutics from RAS blockade, statins, vitamin D and E, bardoxolone, which is not after the studies which have been negative, but again, it has been shown that it has got anti-inflammatory effect, growth hormone, and you have the source reduction with the help of inulin, probiotics, sevelamer, and a visit to a dentist and a visit to a psychiatrist could also be very important to uncover the reasons for the inflammation. I have been using this megestrol acetate for many of my patients with anorexia, and results are also reasonably good. Reduction of IL-1, 6, TNF inhibition improves the appetite. And you have these monoclonals and small molecules, etanercept, anakinra, all these are targeting the TNF alpha, pentoxifylline. So we need to have a multi-pronged attack for this to break these unholy nexus. So the future, large-scale interventions are needed. Specific targets should be identified, and we need to check what are the genetic influences. In fact, I have done studies on patients with CKD, and which have shown that genetic polymorphism of the antioxidant systems in CKD could be one of the reasons why these patients are inflamed. Lifestyle modifications are important, though very difficult on a long-term basis. Thank you very much for your patient listening.